Good.
Dear ESTS members and webinar attendees, as you know, my name is Lieven de Pieper from the Thoracic Surgery Department in Leuven. I am a member of the ESTS Learning Affairs Committee and responsible for the webinars. This is already our third webinar of 2018-2019 series. And the last two webinars, we had over 200 registrants each and over 100 live attendees each. So today will be about the surgical treatment of locally advanced thymoma and thymic carcinoma. I'm very proud to introduce you to our president-elect, Professor Enrico Ruffini, as a guest speaker. He is professor at the Department of Thoracic Surgery in Torino and a leading specialist concerning thymic malignancies. He is the chair of the ESTS Thymic Working Group and author of many publications on this topic. He is co-author of the ESMO guidelines on thymic epithelial tumors and an active member of the International Thymic Malignancy Interest Group. Please, Professor Ruffini, the stage is yours.
Thank you. Thank you, all the participants. And it is a great pleasure for me to give you this lecture, these 30-minute lectures about the treatment, surgical treatment of locally advanced thymomas and thymic carcinomas, which, as we will see, they represent a completely different scenarios. So it's a great pleasure for me. So let's start with the presentation. Okay. Disclosures.
So we have to open to enable the web sharing. We cannot see your presentation yet.
Okay. Okay.
Okay, perfect.
Okay. This is the title of my lecture, Surgical Treatment of Locally Advanced Thymomas and also Thymic Carcinomas. I have no disclosures. This is the overview and what I consider are the learning objectives of this lecture. Some basic background regarding the WHO histology and TNM staging, definition of locally advanced thymomas, some considerations about the surgical issues and the resectability of these locally advanced thymomas, the multidisciplinary strategy, which, as we will see, represents a unique feature of these tumors. The adjuvant treatments, the role of lymphadenectomy, which we will see they are particularly important now that we have a TNM staging system. The treatment of recurrence also. Few words about the thymic carcinoma that we will see are completely different scenarios and completely different presentations. And finally, the new treatments and the take-home messages. We are talking about the thymic tumors. Thymic tumors are really rare cancers. And for the rare cancers, there is a definition. Rare cancers are identified as those with an incidence of less than 6 per 100,000 persons per year. And thymic tumors, as you can see here, represent one of rare cancers. Nonetheless, we have to take into account that annually, rare cancer diagnosis in Europe represents almost 1/5 of all cancer cases diagnosed. The rarity of thymic tumors, of course, has so far represented a limitation to the establishment of what we can consider a robust evidence for the management of this neoplasm. Because most of what we know about the thymic tumors are based on retrospective studies. We have very, very few randomized controlled trials. There are few prospective databases that just started. One is the ESTS, the other one is the ITMIC, and then there's the Chinese. They are slow, sorry, or moderately aggressive malignancies. And this means that we need a very long follow-up to assess any treatment strategy for these tumors. Just to give you a comparison, the vast majority of thymomas present at early stages, almost 70%, as compared to non-small cell lung cancer, where less than 30% of the patients present at early stages. And also the rate of lymph nodal metastasis and distal metastasis is very low, at least for thymomas. We are talking about three completely different tumors. Thymomas, which are organotypic tumors divided in 5 subtypes. Thymic carcinomas, which are non-organotypic tumors. That means that they are tumors that can occur in any other part of the body, but they appear to occur in the thymus. And finally, neuroendocrine thymic tumors, which will not be covered in this lecture. The last WHO classification, histologic classification of thymic tumors include thymomas, further divided into 5 major subtypes, type A, AB, B1, B2, and B3. And the first 3 are so-called low risk of recurrence, low risk of relapse and other things. And type B2 and B3, which are considered high risk. And then we have thymic carcinoma, divided into different subtypes. The most frequent one is the squamous cell carcinoma. And finally, we have the thymic neuroendocrine tumors, and the most frequent is the atypical carcinoid. There is a correlation in thymomas. The higher the differentiation, that means B1, B2, B3, and the higher the stage. This has been demonstrated, and this is why they are called low risk or high risk. B2, B3 are considered high risk. Now we have been using the Masaoka Koga staging classification for almost 40 years, and now we moved to the new TNM staging system for thymic tumors. There is just one staging system for thymic tumors, one for thymomas, and the same for thymic carcinoma, and the same for neuroendocrine thymic tumors. We can divide the different stages into early stages, that means basically stage 1, that now means any tumor that extend up to the mediastinal pleura included. And then locally advanced, that means the initially called the invasive thymomas. That means thymomas invaded the neighboring structures. Stage 2, pericardium. Stage 3A, any potentially resectable mediastinal structure. And the stage 3B, that means a usually unresectable mediastinal structure. And finally, we have the advanced stages. That means thymic tumors extended to the nodes or extended to the as a different pleural implants or distant metastasis. We have developed a thymic nodal map, which divides the locoregional thymic lymph nodes into anterior, perithymic, N1 nodes, and deep intrathoracic or cervical, that is N2. And this is the N categories, N1, N2, N0, N1A, and N1B. This is the stage grouping using the new TNM staging system. Basically, stage 1, 2, 3A, and 3B corresponds to the categories T1, T2, T3, and T4. And then stage 4A corresponds to either N1 or N1A, and stage 4B, it is either N2 or M1B. If we look at stage migration between the Masaoka Koga and the TNM, we immediately see that there is a collapse of many previous stages from stage 1 to stage 3 into stage 1. So now there is a stage migration. For example, the Masaoka Koga stage 3 mediastinal pleura that was initially a stage 3, now it's stage 1. The pericardium is now stage 2, and then stage 3A, 3B, 4A, and 4B. So there now, with the new TNM classification, there is an increased proportion of stage 1 patients, and there is a better stratification of stage 3, and also a better stratification of the N+ involvement. If we look at the different stages, you see here stage 1, stage 2, 3A, 3B, 4A, and 4B. You see that surgery represents the mainstay of therapy across all the stages. This is extremely important for us surgeons. Surgical issues. Which thymomas are to be considered as locally advanced? I think that there are those invasive thymomas which might be completely resected using either surgery alone or surgery in a multidisciplinary approach. And this means the Masaoka Koga stage 3 and 4A and the TNM stage 2, 3A, 3B, and 4A. It is extremely important. These are the two most important prognostic factors in thymic malignancies, the tumor stage and the resection status. That means a complete resection. This is the single most important prognostic factors for any stage, for any tumor, even for recurrence, as we will see. And of course, the complete surgical resection depends on the diameter of the tumor, depends on the staging, and of course depends on histology. The resectability rates, that means the rates of complete resection, R0 resection, decrease with the stage. You see almost 100% in stage 1, and then low, 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 up down to the stage 4. And this is the locally advanced status. How about the axis? We are talking about locally advanced thymic tumors. For locally advanced thymic tumors, so far, the standard approach remains the open approach, and it should be recommended for most centers, and this is what is recommended also in the ESMO guidelines. There are some reports, very good reports, reporting very good results of using minimally invasive approaches, that means bats or rats, to locally advanced thymic tumors. But I would like to emphasize that this should be reserved to highly specialized centers. And I underline this, it should be limited to thymomas. Open approaches are always indicated for locally advanced thymic carcinomas. This is a message that I would like to give you. The surgical axis, the standard surgical axis, of course, is median sternotomy, but the surgeon should be ready to extend the approach, for example, unilaterally or even bilaterally in the chest in case of invasion of the interthoracic structures. The surgeon should be ready to extend using a lower thoracotomy for a better access to the diaphragm. So the surgeon in this case should be flexible to extend the resection, extend the access according to the need. It depends, depending on the different neighboring structures invaded, the surgeon should be ready to, should be prepared to resect all these structures because, as I emphasized, the complete resection is the single most important prognostic factor. The phrenic nerve, I will give you some example later on. The message is that it should be possibly preserved, but it is resectable unilaterally. The venous great vessels, the left innominate vein could be ligated. The superior vena cava cannot be ligated, of course, but it can be tangentially resected or bypassed. The pericardium, that means TNM stage 2, is resectable. It can be covered by mesh. The lung is resectable with no major problem, and the chest wall, of course, is resectable. What if the resection is not complete? This is a meta-analysis that was published a few years ago about the role of debulking surgery versus simple biopsy. And the conclusion of the authors were that surgery, even with a debulking intent, is preferable to simple biopsy in rather unresectable thymomas. There is very little evidence that this is true for thymic carcinoma. So for thymic carcinoma, probably this is not true, but for thymomas, I think that it can be advisable. Sorry. The phrenic nerve involvement. The phrenic nerve should be preserved because sometimes in these patients are with myasthenia gravis, of course, and the resection of one phrenic nerve can affect, of course, the postoperative course. But unilateral phrenic nerve resection is acceptable. The bilateral phrenic nerve resection, of course, is to be avoided. And in case of resection of the phrenic nerve, some authors recommend the diaphragmatic ligation in order to avoid the problem with the elevation of the hemidiaphragm. These are some examples from our series about the different phrenic nerve involvement. Sometimes the phrenic nerve was spared, sometimes the phrenic nerve was sacrificed. And a few years ago, the group in Paris published this paper where they analyzed the phrenic nerve involvement. Sometimes the phrenic nerve was spared, sometimes was removed. And what the authors found was that when the phrenic nerve was removed, there was a lower rate of local recurrence, but the overall survival rate are similar if the phrenic nerve is spared or if it is sacrificed. Great vessel involvement, in this case, consider induction therapy. Chemotherapy is better than chemoradiotherapy. The ligation of the left innominate vein is acceptable. And in case of resection of the superior vena cava, there are some series here. There are a few years ago, but now they are still valid, I think, with a very low mortality and an acceptable 5-year survival in case of SVC resection and reconstruction. This is an example of huge involvement of the left innominate vein. In this case, we proceeded with the resection. This is the huge thymoma here. You see we performed the resection of the thymoma, left innominate vein ligation, partial pericardial resection, phrenic nerve sparing, and in the end, it was an R0 resection. In this case, it was an MG-associated thymoma, locally advanced. This is a case that we performed last week. You see here the phrenic nerve that goes directly into the mass. And so in this case, when the phrenic nerve is invaded, particularly in a young woman, I think that unilateral resection of the phrenic nerve is acceptable and should be performed. My comment is always document it with pictures, also for any medical legal issue. The same case had an invasion of the left innominate vein, and you see here after the resection what was left of the left innominate vein. So very thin stripe of the left innominate vein. In this case, I don't think that there would be any case for the reconstruction of the left innominate vein, because consider this, that the patch of the vein graft exposes to the risk of thrombosis, because the venous system is a low pressure system, and there is no problem if there is a thrombosis of the left innominate vein, But the problem is that the thrombosis can extend backward to the SVC, and in this case, you are in great trouble. So in this case, we always prefer to ligate the left innominate vein with a very tangential, you see here, very tangential resection of the left innominate vein at the confluence of the SVC. And this is the specimen. You see the lung. So we always perform a wedge resection of the lung, the upper thymic pulse. This is a thymoma, and this is the left innominate vein. And again, this was an R0 resection. This was another case that we did 1 month ago. In this case, we were able to partially resect the wall of the left innominate vein and reconstruct it. And the patient did quite well. You see here the pericardium was invaded here, and this is the left innominate vein. And again, we were able to do a R0 resection. Sorry. In case of partial involvement of the SVC, a tangential resection of the SVC could be done, like in this case. In other cases, when there is a major involvement of the SVC and even in the left, even of the right atrium, in this case, there was a reconstruction of the whole system. You see here, the left innominate vein was ligated, and the graft was constructed between the right innominate vein and the atriocaval junction. In stage 4A means that the tumor invades the pleura or pericardial in form of different implants. The implants can be single, multiple, discrete, or diffuse. And in this case, the complete resection rate varies among the different series. We have different options. We can just resect the different pleural implants, which is called the limited pleurectomy. We can do a total pleurectomy. We can do an even an extrapleural pneumonectomy, and we can also add some intracaritary treatments like the hyperthermic chemotherapy. This is the case from our archives, a resection of the pleural implant on the diaphragm. You see the lever behind, and in this case, it was extrapleural pneumonectomy was performed. The ESTS thymic database, thymic group, using the ESTS database published a few years ago, the results of the surgical therapy of thymic tumors with pleural involvement. And what we found is that, once again, if we are able to perform a complete resection, irrespective of the technique that we use, limited pleurectomy, total pleurectomy, even extrapleural pneumonectomy, the results are extremely good. You see here the different curves here, the R0 versus R1 and R2. I would like also to emphasize that once again, thymic carcinoma, you see here, the results are far worse than in thymoma. So a word of caution to use surgery in case of thymic carcinomas. Sorry, I just recovered from a flu. This is another case. This was a stage 4 at presentation after induction chemotherapy, restaging, surgery, thymoma, SVC tangential resection of the right pleural implants, postoperative radiotherapy, postoperative chemotherapy. The results are very good, alive and free from recurrence 4 years following surgery. The use of hyperthermic endothoracic chemotherapy, we do not have in our institution experience of this. I just report what I found in the literature. In general, the preliminary results are quite promising, but a word of caution again for thymic carcinoma, also for thymomas, and but only in very experienced centers. This is the message. Recurrence, just few words about the recurrence of tumors. The recurrence of thymic tumors depends on the stage at presentation. The locally advanced thymomas usually recurs with a higher percentage in the higher percentage of cases, from 20 to up to 50%. cases. The use of postoperative radiotherapy seems to decrease the recurrence rate. I will show you later on. There are some patterns of recurrence. The tumors can recur locally, regionally, or distantly. And again, surgery represents the option. The average time to recurrence is 5 years. So we are in the presence of very slow growing tumors. Whenever possible, surgery should be proposed. Again, once again, if the resection is complete, the results are similar to the results of the primary surgery. The role of pre- and postoperative radiotherapy and chemotherapy is unclear, and this is a series that we published a few years ago, 81 patients treated in 3 centers, where surgery was used in most of the cases. And again, you see here that in any case that we could perform a complete resection, the results are much better. And once again, in case of thymic carcinoma, the results are very low. Locally advanced thymomas, thymic tumors, usually benefit from a multidisciplinary approach. The historical results of using surgery alone are quite disappointing, you see here. Good, but not exceptional. And these are the most recent series using a multidisciplinary approach. Multidisciplinary approach means to use chemotherapy, surgery, and radiotherapy. But how? Chemotherapy can be used as an induction in an induction setting, or can be used postoperatively. Well, this is a meta-analysis demonstrated a few years ago that there are favorable rates of long-term overall survival in patients with locally advanced thymic tumors undergoing induction therapy and surgical resection. Unfortunately, this was not confirmed by other series like this. Again, this, using the ESTS thymic database, we were unable to demonstrate a good role of induction therapy in these tumors. But we were able to demonstrate the efficacy of adjuvant therapy in prolonging overall survival and disease-free survival. And this is replicated by many other series and meta-analyses. I will show you this. For example, the message is always the same. That means that the evidence for induction therapy is, let's say, moderate, but the evidence for postoperative radiotherapy is much more robust, particularly for invasive thymomas, which are the thymomas we are now speaking about. That means thymomas stage 2, 3, and 4A. And these are the results from most series. Again, like this. This was published last year. Postoperative radiotherapy is effective after complete resection in any stage more than 2B in thymomas and thymic carcinomas. Again, this is another one that was published 2 years ago. Postoperative radiotherapy is beneficial after complete resection in invasive thymomas, locally advanced thymomas. Again, another one confirming the same results. So, just to summarize, the multidisciplinary approach is indicated in all locally advanced thymomas. Discussion in a multidisciplinary tumor board is recommended for these tumors. The surgeon should take the lead in this case, because the decision of the surgeon is crucial. In any locally advanced thymic tumor, the surgeon is asked to judge if the tumor is resectable upfront or not. In case the surgeon decides that the tumor is resectable upfront, then we have to proceed with surgery. If the surgeon decides that the tumor is not resectable upfront, then induction therapy is a good option. And then let's see the response. Although, of course, I demonstrated that induction therapy the evidence is so far moderate. There is much robust evidence that postoperative radiotherapy is beneficial for any invasive thymoma after any resection, complete and not complete. Let's move to another important issue in locally advanced thymic tumors, the role of lymph node dissection. We have a thymic nodal map, you see here. We divide the regional thymic nodes into the anterior region and deep intrathoracic region. This is the anterior region, and I would like to emphasize that the ISLAC lung cancer map level number 6 is not N2, but it is N1. In this case, it is N2 in the lung cancer nodal map. In the deep region, this is the deep region, that means middle mediastinum and the deep cervical nodes. And these are the region according to the CT you see here. There is evidence that the lymph node involvement in thymic tumors is a worse prognostic factor. We were unable to demonstrate any difference in N1 versus N2 using the ISLAC database that constituted the backbone of the new TNM staging system, because we have too limited data. The only data that we had about the nodes were those from the JERT, the Japanese Association for the Research on Thymus. And with this data, we were unable to demonstrate that there is a difference between N1 and N2, but we were able to demonstrate that the N+ status portends a bad prognosis. There are some ITMIC recommendations for the lymph node dissection in thymic tumors according to the stage and according to the histology. So basically, the pedithymic nodes usually are included in the resected specimen. So we do not have to worry about that. The pathologist can look at that. We are asked to remove the N1 stations for any thymomas, and we are asked to remove the N2 stations in case of locally advanced stage 3 and more thymomas and in any thymic carcinomas. And these are some series. And this is an interesting paper that was published very recently. And the authors were able to demonstrate that the more intentional you look for the lymph nodes, the more lymph nodes you found. And actually, with an intentional lymph node dissection, that means they actually went there to look for the nodes. They were able to demonstrate a very high prevalence of lymph node metastasis in thymomas and in thymic carcinomas and in neuroendocrine thymic tumor. This is an important message for us surgeons. And the same with this other Korean manuscript. And the same authors demonstrate, you see here, the nicely stratification between the N0, N1, and N2 in thymic carcinomas, in thymic tumors, sorry. And this is just a summary of the different contribution to the lymphadenectomy. All these authors found that the outcome is worse in case of N+ disease in thymic tumors as well. So the summary for the lymph node dissection is that now we have a new TNM staging, and we are asked to perform a lymph node dissection according to the ITMIC recommendations and to the ITMIC ISLAC thymic nodal map. For locally advanced thymomas, N1 dissection other than pedithymic is recommended. For more advanced thymomas, stage 3 and stage 4A, the sampling of appropriate N2 station is recommended. Thymic carcinoma is a completely different story. You see here the different survivals between thymomas and thymic carcinomas. The surgical principles are very similar, but we have to expect a lower complete resection, a higher prevalence of N+ disease. A multidisciplinary approach is always indicated in this case. The role of postoperative radiotherapy is robust in this case. The evidence for postoperative radiotherapy in thymic carcinoma is much more robust. Moderate for the use of chemotherapy. So postoperative radiotherapy for thymic carcinoma is more robust. You see here, I listed here all the most recent series of thymic carcinomas, the result of the surgical surgery. And you see here that 5-year survival is far less than in thymomas. So we are moving to the end of the lecture. I would like to summarize which is the management of the locally advanced thymic tumors according to the current guidelines. We have two guidelines, current guidelines, the NCCN guidelines and the ESMO guidelines. I would like to refer to the ESMO guidelines because we are European, of course, and we have different scenarios like here. So thymic tumors resectable upfront in case of thymoma, okay? Complete resection, early stages, nothing else other than surgery. Stage 2B, high risk, like in this case, high risk cases, in this case, postoperative radiotherapy is indicated, even in case of complete resection. In case of incomplete resection, thymomas, incomplete resection, any stage, postoperative radiotherapy. Thymic carcinoma, resectable up front, again, here, you see here, early stages, any histological subtype, postoperative radiotherapy is indicated. Surgery alone is not enough for thymic carcinoma. And the same for higher stages, here, the adjunct of postoperative chemotherapy is advisable. So again, multidisciplinary treatment for thymic carcinoma, always. In case of tumors unresectable up front, locally advanced, primary chemotherapy, restaging, dim resectable, surgery. In case of thymoma, complete resection, postoperative radiotherapy is indicated. Incomplete resection, postoperative chemotherapy and radiotherapy. In case of thymic carcinoma, chemoradiotherapy in any case, in any stage, in any arm. Finally, last scenario, tumors considered unresectable up front, they receive primary chemotherapy, they still remain unresectable. In this case, chemoradiotherapy for thymomas, chemoradiotherapy for thymic carcinomas. Targeted therapies, just a couple of slides. There are some studies ongoing investigating the role of a KIT overexpression for most of these studies are dealing with thymic carcinomas and not for thymomas. This is another example. This is a quite recent study investigating the role of sunitinib, which is a KIT inhibitor, in patients with chemotherapy refractory thymoma and thymic carcinoma. These are the results for thymic carcinoma, and you see from the waterfall figure here that the results are much better than thymomas. How about immunotherapy? There is a good expression of PD-L1 in thymoma and in thymic carcinoma. But remember that in thymoma, so far, the use of immuno-oncology in thymoma is currently limited to the serious adverse events due to the immune-associated syndrome, myasthenia gravis. And so most of the studies now are focused on the pembrolizumab immuno-oncology in thymic carcinoma, with some very good preliminary good results. Okay, so back to the take-home messages. I divided locally advanced thymomas and, of course, thymic carcinomas. Locally advanced thymomas, that means stage 2, 3A, 3B, 4A, according to the TNM staging, represents about 30 to 40% of thymomas. Surgery is the mainstay of therapy. The complete resection is the goal. Surgery is indicated if the tumor is considered resectable up front. Induction therapy is indicated in initially unresectable tumors. Postoperative radiotherapy is always indicated, irrespective of the R status. There is a more robust evidence. Extended resections are indicated even in stage 4A tumors, provided, again, a complete resection is accomplished. There are some indication using the ITMIG recommendation about the lymph node dissection N1 and selected N2 stations. There are limited results for immunotherapy for thymomas due to the severe adverse event of associated immune syndrome. And for thymic carcinoma is a completely separate entity from thymoma. with more advanced stage presentation, more aggressive behavior, higher prevalence of end metastasis, but the same principles of other thymic tumors apply to thymic carcinoma. Thank God we have a similar TNM system. Surgery, again, with a complete resection represent the main therapy, and for all thymic carcinomas, a multidisciplinary treatment is indicated. The lymph node dissection should extend, in case of thymic carcinoma, to N1 and N2 stations. Adjuvant therapy is indicated in all stages. There is a good evidence for port, less evidence for chemotherapy. And contrary to thymomas, there are preliminary good results for targeted therapy, sunitinib, and immunotherapy in chemotherapy refractory diseases. Thank you very much for your attention. I'm open, of course, to any question.
Okay. Thank you, Mr. Ruffini. I see some questions. One concern I see, if you had a flu vaccination or not. But the other questions are, is there any role for intraoperative chemotherapy? I saw you mention this, you just mentioned it in your slides, but there's no really guideline, I think, for this kind of therapy.
Okay, I just type my answer. Okay.
No, you can just answer.
You can just say, okay. So there is absolutely no guidelines for intraoperative therapy for this, because the cases are too few, and there's a limited experience from very small number of series. So I cannot give any recommendation for this, particularly because I have no first-hand experience in this. This is for the HITOC in the hyperthermic intraoperative chemotherapy. How difficult is the VAT surgery?
Can I just interrupt you? If you close your enable web sharing or enable web screen sharing, then you can.
Yes.
People can see you much better. Yes, like this.
Okay, thank you. How difficult is the VAT surgery after new adjuvant chemo radiation? It is difficult. It is difficult. We do not have any experience in VATs after new adjuvant chemotherapy or chemoradiation therapy in thymic tumors. We tried a couple of robotic resections for local invasive thymic tumors invading the pericardium and invading the lung, of course, which is not a big deal. But I would not recommend for the average center, as I showed in my presentation, to start a resection using a minimally invasive approach in case of locally advanced thymoma. This is my advice. Define LIV, yes. Okay, left innominate vein. Sorry for acronym. Preoperative biopsy. This is a very, very good question. It's a very good question for different reasons. When I performed a survey a few years ago among the ESTS thymic community, asking a few questions about the different management of thymic tumors. One of the questions was, do you use a preoperative, always a preoperative histologic confirmation of an anterior mediastinal mass? And surprisingly, more than 80%, 85% of the center responded no. So I do not use that. And this was replicated in other similar surveys that I found in the literature. But I think that now, I think we have to change our mind, because the lymphadenectomy now is mandatory. And I think that in order to tailor the lymphadenectomy N1 and 2 stations, probably we need a correct histology, beforehand. And so maybe if we can have a preoperative histology, maybe we can tailor our lymphadenectomy, our strategy intraoperatively. Okay. One reason to perform a preoperative biopsy is when the tumor is considered unresectable. If the tumor is considered unresectable, you need a preoperative biopsy, of course, because you need to start a neoadjuvant treatment. And you need to know if the tumor is a thymic carcinoma or if the tumor is a thymoma.
Okay. And the concern, if you do a biopsy, that you can cause any pleural spreading or anything, that's not a concern?
No, okay. We had a lot of debate of this in Barcelona at the joint international meeting a few weeks ago, and all the panelists agreed that the evidence for seeding is so low, so anecdotal, that I think that we can discard it. The risk of seeding can be discarded. Let's look. Is there any role? Okay, please define how difficult preoperative. Okay, what the clinical consequences of ligation? What happened to the patient post-op? Did we recommend pleurectomy? Okay. Regards to the Abdul Almu. Okay. The first question is, what are the clinical consequences of a left innominate vein ligation? The only consequence that you can find post-operative is, let's say, for the first 48 hours, a kind of swelling of the face, and of course, a swelling of the left arm. But using judicious use of diuretics and elevation of the arm, usually this is not a major problem after 48 hours. The patient that I show you that was operated last Wednesday, I saw her this morning in the ward, and her face is completely okay, and also the arms are completely okay. So it is not a big concern. Okay.
Okay.
The second question: do you recommend pleurectomy for MPM-like mesothelioma? Yes. There is no need to use the same principle that we use for the mesothelioma surgery, because usually the stage 4A pleural involvement in thymic tumors are usually discrete nodules. So there is no need for a completely total pleurectomy unless you have a diffuse involvement. But if you have only scattered different pleural implants, if you, with patients, of course, take out all the pleural implants, this is okay. This is a complete resection. Okay, so there is no need for a prophylactic total pleurectomy in case of pleural involvement from thymomas.
And the deep dissection?
How do you perform deep node dissection? Yes, deep node dissection. There is no need to perform a complete lymphadenectomy of all the deep, because it has been demonstrated that the most frequent N2 involved stations are the 4R, the right lower paratracheal nodes, which are, let's say, easily accessible using different techniques. So my suggestion is at least to sample, not to do a radical lymphadenectomy, but just to sample at least the 4R and the 4L nodes. This is enough for ITMIC.
About the
anticoagulation. Anticoagulation after, okay. After ligation of the left innominate vein, no, I don't think that there is any need for anticoagulation, because usually the distal stump of the left innominate vein probably will get thrombosed again. The flow as long as you do a very tangential resection of the left innominate vein, in order not to leave any stump in the superior vena cava, I think there is no need This is what our vascular surgeons recommend. There is no need for an increased anticoagulation.
Okay, and will you do reconstruction?
In case of reconstruction, yes, of course. In case
and
of
what do you use then?
Usually a normal anticoagulation dose that for an average for an average patients, we usually do 6,000 heparin 2 times a day.
Okay, and for how long?
At least for 4 weeks, let's say, and then probably to change into oral for a few months.
Okay.
I would suggest. Okay.
So the next question was about the overall survival between resection or leaving the phrenic nerve.
Yeah. There is no survival thymoma. What's the point to resect it only to reach an R0? Okay. This is a good point. Yes. But I think that the authors demonstrated that yes, overall survival is the same, but if you spare an involved phrenic nerve, there is a higher chance of recurrence.
No.
This has been demonstrated, and a higher chance of recurrence also means that myasthenia can recur. So in these patients, I think that as long as you can get a R0 resection, particularly in young patients, I think that the sacrifice of a unilateral phrenic nerve is recommended.
Okay.
This is my position.
The role of surgery in case of N2 involvement.
Yes. So yes, and N2 means stage 4B, which means that maybe surgery is not indicated. But how can you say that it's an N2 involvement unless you operate on this patient? So we do not have enough data to see if these patients, unless you perform, let's say, a VAMLA, TEMLA, mediastinoscopy, or other things. But again, I would distinguish between thymomas and thymic carcinomas. Locally advanced N2 pleural involved thymic carcinomas, in that case, probably surgery is not indicated. But pleural involvement N2 thymomas, I think that in that case, surgery is indicated. Because don't forget that even for high stages, the overall survival is not that bad. It is not the stage 4 of lung cancer. We are talking about stage 4 thymic tumors. That means that even in stage 4, the 5-year survival is around 40%. So definitely completely different figures than for lung cancer. So I would recommend surgery for N2 thymomas, not maybe for N2 carcinoma, thymic carcinomas.
Okay. Then the question about the vein replacement, we already answered this one.
Yes, okay.
And then the patched vessel how do you manage it with postoperative radiotherapy? Is there a higher risk of thrombosis or patch rupture?
Yeah, there is a very little evidence in the literature. Very little. I checked, I looked for the literature, but it doesn't seem to be any major concern about that, according to what I read. But there are very, very few reports on that.
Okay, and then maybe also about postoperative radiotherapy. I also had a question: what fields do you irradiate? Because if you have the patient with the pleural mets, is this really the whole pleural cavity, the whole field? How large is your field if you do the postoperative radiotherapy?
Usually, I'm not an expert in radiotherapy, of course, but from what I understood from my colleagues, radiotherapists, I think that usually the bed, the tumor bed is usually the mediastinum. Okay. And if you have the IMRT, maybe that is much better for the pleural space, particularly if there is the lung, because otherwise you can expose the patient to some high risk by irradiating irradiating the lung. We in our institution we have IMRT, and IMRT can somehow protect the lung much better than conformal normal.
Okay.
Okay, so
advice for the material if you have to reconstruct a vein.
It doesn't involve the vein graft, but what material did you do? The left. We use the most recent one that we did. We used PTFE.
PTFE. Okay.
PTFE. Yeah. The diaphragm plication after phrenic nerve resection. We do not have we do not have done that for the last few years, and we didn't know any difference, let's say. So we didn't experience any particular problem not plicating the diaphragm. So of course it depends on your post-operative chest X-ray, because it is absolutely unpredictable the height of the hemidiaphragm after phrenic nerve resection. For example, the last patients last week, we sacrificed the phrenic nerve, but there is a very small elevation of the hemidiaphragm in that case, and we didn't plicate. Okay, there are other cases when the hemidiaphragm is very high, and in that case, maybe plication is recommended. But I think that in our experience, we have done it no more than 2 or 3 times.
Okay. Then there was a case of a young male patient, thymectomy, open thymectomy for 4 centimeters, transcapsular invasion. What do you recommend postoperatively? Postoperative radiotherapy or not? But I'm not sure. Thymic carcinoid is there? Is this a carcinoma or not? I don't know.
Yeah. Thymic carcinoma, neuroendocrine thymic tumors are so rare that we do not have any particular guidelines, and we have to navigate at sight, as we say. But I think yes, neuroendocrine thymic tumors are extremely aggressive tumors, and I think that in these cases, postoperative radiotherapy is definitely indicated. This is my personal opinion in this case.
Okay. And then the biopsy, to come back on the biopsy, what do you prefer, the needle core biopsy or the surgical biopsy?
No, needle. I think needle core biopsy is enough. Usually there is enough material. We used to perform in the past anterior mediastinotomy, like here with the removal of the cartilage. And of course, in that case, a big chunk of tissue came out. But I don't think that in this case there is need for that. I think that needle core biopsy is enough as a preoperative biopsy.
Perfect. And then the last question was about the authors who claim that in case of preoperative and postoperative chemoradiation therapy, the completeness of the resection is questionable.
What can you say about some authors who claim the case of preoperative induction and postoperative chemotherapy, the completeness of resection is questionable? Yes, usually as an induction therapy, you use chemotherapy, and then we do not tend to use again chemotherapy postoperatively. We use postoperatively radiotherapy. The complete. I didn't understand the question.
I also don't understand it about the authors who claim the case. So if Lula Joseph can make his question a little bit more specific, then we can go to the other one. Yeah. About the rate of thoracic surgeons performing lymphadenectomy. Do you have a clue?
Yes, I have an idea, because we circulated a survey on behalf of the International Association for the Study of Lung Cancer Staging Project And again, I developed a questionnaire, and one of the questions was, how often do you perform a lymphadenectomy?
Mm-hmm.
And of course, I divided thymomas and thymic carcinomas. And surprisingly, N1 lymph node dissection is performed in more than 70% of the thymomas and thymic carcinomas, and N2 lymph node dissection is performed in less than 30% of the cases, in the thymic carcinoma, if I remember well, and in 40% in thymic carcinoma, which is quite good. I don't know if you know that surveys sometimes should be taken into account as I mean, the reliability of the survey. But we were impressed in the staging committee because still there are many surgeons performing lymphadenectomy in this. And since the introduction of the new TNM staging system in our institution, yes, we started to meticulously found the different lymph nodes. And it is true that the more intentional you look for, and the more lymph nodes you find. And also you have to educate your pathologists, because if your pathologists are asked to find the lymph nodes, they found a lot of lymph nodes in the specimen, much more than expected. They simply didn't report it in the past because they didn't look at them. But now that you have to educate them, and in that case, you will be surprised by the number of lymph nodes they find.
And also, if they perform in thymic. So let's start with thymoma. And then I'll send out a poll. So if in your right sidebar you can find a poll, yes or no. I typed "ni." I'm sorry.
Fantastic.
So then we can see how our audience is working on that.
Oh, that's interesting.
I will ask the same question again in thymic carcinoma. Let's see how that works out. So here it's 50-50, but we still have 60 attendees, so some more people can answer, I think.
Yeah, interesting. You see more than expected. Eh?
Well, maybe after your talk, they don't dare to say no anymore. Okay, we have the specified question of
90%. I think this is a very good compliance to the to the ITMIC guidelines and to the ITMIC recommendations. So congratulations.
Indeed. So if you go back to the questions, we have the question of Lula Joseph again. Some authors allege that the previous case with the pre and post-operative treatment, there is no need to achieve a complete resection. So the post-operative radiotherapy will do the rest. What do you think?
No. There is no evidence for that. Once again, the single major prognostic factor is the complete resection, and all other treatments are ancillary, let's say. So that means the preparation and the consolidation of the complete resection. Induction therapy is the preparation to the complete resection, and postoperative radiotherapy is the consolidation of your complete resection. But again, the center of the stage is the complete resection. I would like to emphasize this. So it is extremely important to, and the surgeon should be prepared to take some risk also. Again, be prepared to ask for the vascular surgeons maybe to replace the SPC, if he or she is not able to do that, to reconstruct the diaphragm, to reconstruct the pericardium, because this is extremely rewarding. An incomplete resection exposes to the risk of recurrence. There is no question about that, irrespective of postoperative radiotherapy or not.
You prepared a lot of questions for the audience, so I will launch some of them. Then we can see if they.
The relationship between myasthenia gravis and thymoma and thymic carcinomas. Okay, yes. So let's say that we can say that around from 30 to 40% of the patients with thymoma have myasthenia gravis, but remember that thymic carcinoma is hardly ever, according to some pathologists, it is never associated with myasthenia gravis. Okay, so the relationship is from thymoma and myasthenia gravis, but not thymic carcinoma and myasthenia gravis. Okay, this should be very clear. And this is something that also the neurologists are not aware of. Sometimes they say, no, this patient has a myasthenia gravis and probably a thymic carcinoma. Very, very, very unlikely. There are very occasional, only anecdotal report of patients with the thymic carcinoma and myasthenia gravis. And actually, they were questioned that maybe that was not a thymic carcinoma, but it was a B3. That means a well-differentiated thymic carcinoma, which is a thymoma. It is not a thymic carcinoma.
Okay.
So this is thank you for the questions. I think it was a very good question.
Yes. Any experience with reconstruction of the phrenic nerve?
Yes, we did it once, and I don't know, it worked. Let's say that we removed the thymoma, and then we had the two stumps of the phrenic nerve, and so instead of just clipping, we just sutured them, and that's it. We covered with some. I don't remember, some mediastinal fat pad, and that's it. And apparently it worked. Let's say that in the postoperative period, the diaphragm was not elevated. So this is the single one experience that we have. It is not a graft. It is just a simple direct suture of the phrenic nerve. I would not give any recommendation about that, of course.
Okay. And the risk of peritoneal metastasis after diaphragmatic resection?
Diaphragmatic resection for implants, I haven't read of any report. I confess my ignorance. I haven't read of any report, like in mesothelioma patients, of seeding, but maybe it's my fault. I don't know.
Okay. So to see if everyone has well understood your presentation, I launched your questions, Professor Ruffini, in the polls, so we can see if this is correct, what the audience is answering.
I hope so.
So the first one was following the recommendations about lymph node dissection in locally advanced thymic carcinomas. Is this what is not correct? In the polls.
Yes.
So not in the questions, but in the polls.
I cannot see the end of the column. But I see the bars. Okay, I don't see the percentage, but I see the bars. Yes, perfect. Okay, correct.
So the fourth was with 67% of the audience. Lymph node dissection is not recommended, only in case of. Is that correct?
Which of the following is not correct? The only one which is not correct is the number 4. Mm-hmm.
Yeah, indeed.
Okay.
Another one was also what is not correct. Minimally invasive approach in the management of locally advanced thymic tumors. So not correct. The most of the answers was they are recommended approaches according to the ESMO guidelines.
Yes.
I think this is indeed not correct.
Yeah.
But this was a bit difficult because 30% of the audience was answering answer 3, and 20% was answering answer 4.
Yeah.
So it is answer 1.
They are both true statements.
Yes.
They should never be considered in locally advanced thymic carcinoma. And I think this should be very clear from my presentation. So I would never recommend using minimally invasive techniques in case of locally advanced thymic carcinoma, because the risk of invasive tumors, the risk of getting into trouble is very high, even in experienced centers. And the number 3, I think it is true. In locally advanced, they can be considered in selected patients by experience. Maybe they thought that the thymic carcinomas was included here.
Yeah.
Yeah. But again, the single statement which is not correct is number 1.
Mm-hmm.
Okay.
Okay, and then the other one was clear. What is the role of surgery? It's applicable in all if you can become an R0 section.
Okay.
The next one, the current evidence for postoperative radiotherapy. I think indeed this one is strong, as you mentioned. Okay. So this is very, very good. And the current evidence to use induction therapy. Is this weak, moderate, or strong? Most of the audience think it's moderate.
Yeah, yeah. Weak also is, I think it's correct, but moderate. I think moderate is the right adjective to me. Mm-hmm. Okay. Okay.
Going back to a question, there's just one question that came in. What are 5 risk factors for thymoma and thymic carcinoma? So the risk factors to have one, or?
Yeah, this is not clear. What are the 5 risk factors for thymoma and thymic carcinoma?
Risk factors for recurrence, risk factor to have. I don't know.
I don't know if he refers to a prognostic factor.
Can be.
Mm-hmm. Again, histology has not been considered a validated prognostic factor except for thymic carcinoma. But the different histotypes, the different subtypes of thymomas, they are not a prognostic factor. That means that B2 or B3 are not significantly different between each other, So histology is a prognostic factor, but only for thymic carcinoma. First. Second, the stage. Yes, stage is a prognostic factor. Thank God, because this means that we did a good job in the staging committee. And third, the completeness of the resection. So these are the 3 most important prognostic factors for thymic tumors: histology, thymic carcinoma, and of course neuroendocrine thymic tumors. But they are so rare that histology, thymic carcinoma, stage, according to the TNM, and the completeness of the resection. These are the 3 single most important prognostic factors.
Okay.
Myasthenia gravis is not a prognostic factor, for example.
Perfect. Then, Professor Ruffini, I would like to thank you for your webinar, the whole presentation and discussion of all these questions. It's 7:15, so we worked already for 1 hour and a quarter, which is very good. We had a lot of interaction, which is also good, and we had more than 70 live attendees. So thank you everyone for attending. Thank you, Professor Ruffini, for the presentation. And I think within a month, about 1 month, we see each other again on esophageal cancer. Thank you.
Thank
Bye.
you. And Merry Christmas to everyone. And
okay.
Okay. Thank you.
Thank you. Goodbye.
Bye. Bye, Lieven.